Welcome back to Part 2, Classification and Assessment of Abnormal Behavior on Clinical Assessment and Testing. Just to recap, for diagnosis, we need information on psychological, biological, and social factors that could be influencing a person and contributing to the disorder or symptoms that they're manifesting. The process of diagnosis helps clinicians narrow the focus by helping them rule out certain problems and then focus in on concentrating on others. This is done through a broad range of tests and tools that are often used in order to assess the client. And we're only going to talk briefly in this lecture about some of the methods that are used for assessment and some of the psychological tests. But before we go into this too deeply, first we need to make sure that you understand two incredibly important concepts when it comes to assessment of psychological disorders: reliability and validity. Reliability refers to the extent to which things are consistent. Going back to what we discussed earlier, when they were looking at if clinicians were coming up with the same diagnosis when given the same information, that was a question of reliability. It wasn't necessarily asking, are they accurate, are they correct, but is it the same? Is it the same between people, and is it the same over time? Inter-rater reliability measures the extent to which two or more raters, or clinicians, get the same answers and the same results when they look at the same information. Test-retest reliability measures the extent to which something is consistent across time. If I give you an IQ test on Tuesday and then you take it again a week later, you should get the same results, at least to the extent to which IQ is considered a stable construct. Reliability is incredibly important. As you recall, the problem with the earlier DSMs was that they did not even meet the basics for reliability. People could be looking at the criteria, looking at the same data, and not come up with the same conclusions. Without reliability, we don't even get to the point of having a conversation about the second construct of validity. Validity refers to the degree to which an instrument or a process is measuring what it is designed to measure. As an example, if I'm giving you a test of extroversion, it should be truly measuring extroversion and not measuring some other construct like impulsivity or one's activity level. And here there's a lot of different types, but two important ones for diagnosis and assessment are concurrent validity is comparing the results of one measure to other measures that are already known to accurately be looking at the same thing. If I give my new measure of extroversion and I compare the findings of my measure to the findings on a measure that is already proven to examine extroversion, am I getting the same accurate information across both measures? And then predictive validity, which is perhaps the most important when we're talking about human beings and clinical assessment. Our assessment tools should accurately allow us to predict what is likely to happen in the future. If your test truly measures what you think it does, you should be able to predict some behavior based on the scores of that measure. Again, if I gave you a measure of extroversion and somebody scores very highly on extroversion, we should be able to predict their ease at being in a social situation or a party the next day. And if people are high on extroversion, we should see behaviors at a party that are consistent with someone who is high on extroversion. The examples I gave largely talked about reliability and extroversion in the sense of measures or tests that we might give out. But we can also conduct an assessment using clinical interview, projective tests, and personality inventories. And we're going to go into each of these in turn. Typically, when one is involved in psychological testing, a clinical interview is going to be the first step that is important for all clinicians. And many will then use additional tests or measures to supplement that clinical interview. Clinical interviews can be unstructured, where the person is simply asking questions. But remember, that was one of the problems we talked about with the early versions of the DSM, that clinicians asked different questions and they ended up coming up with different diagnoses. A gold star of clinical interviewing is a structured clinical interview, where they are required to go through a series of questions with branching trees that will stem to those diagnoses they should consider and eliminate those that they don't qualify for. In addition to the clinical interview, as I mentioned, people will often use psychological tests to supplement that info. Think of some of the reasons why this might be really important to do. Well, one, it's another source of concurrent validity. If in my clinical interview I assess that the person appears to have some anxiety, I can then look at these psychological measures and determine, did they also show that this individual had some anxiety? Clinical tests are also often very, very fast. We can gather far more information by having them complete the test than we could do in a single clinical interview. They also avoid the clinical bias that the clinician may be bringing to the table. So I might sit down with someone and I make an assessment based on what I see when I look at them. But a clinical test doesn't see a person, so it removes at least that layer of bias. And the nice thing is, when we are looking at the results, we don't have to think about it just for this person. We can go to the clinical research and look at lots and lots of data that will give us information about how people with these kinds of scores typically do down the road. In talking about psychological tests, we're going to go over two broad categories today: projective tests and then the personality inventories. There are lots of projective tests out there in the world. They have a very, very, very long history, going back over 100 years, and are based largely on psychoanalytic theory. The idea here is that people are presented with ambiguous stimuli. This might be pictures, situations that they're asked to describe, but they're asked to give information about something that's ambiguous. And because it is ambiguous, it allows their unconscious personality, thoughts, and beliefs to come through and be projected onto that ambiguous stimuli. Without even realizing they're doing so, they find themselves revealing some patterns of unconscious thoughts and thinking. Perhaps the most famous one is the Rorschach Inkblot test. The Rorschach is perhaps the most famous and well-known of all of the projective tests. It consists of a series of inkblot pictures and asks the person to tell the clinician what they're seeing inside that inkblot. The answers are then used to diagnose psychopathology. For example, if a person gave a lot of answers that focused on the shadings of the inkblots, they might be diagnosed with schizophrenia or major depression. But this is a very controversial test with a lot of controversial uses. In the very early days, therapists were administering it any way that they saw fit. Some therapists asked for a one-word response on a picture. Others might ask them to give a 5-minute response. Others would say, give me lots of responses or tell me a story. And this resulted in the Rorschach not being very reliable, with clinicians getting different responses and different diagnoses, which inherently also rendered it invalid. In response to the many challenges, John Exner developed a more standardized version of the Inkblot test and created a comprehensive system that specifies how the cards should be presented to a client, what the examiner should say, and how those responses are to be recorded. From there, their records are put into an extensive system coding each of those responses on a variety of factors, whether or not they were using the white space or the shadow space, were they using the entire picture or just a segment of the picture, was the item they saw something that is very normative, something they called poplars, or was it something that no one has really said before? Each particular card might have 20 responses to it because you're asked to have them look at the card one direction, turn it over, look at it on its side, and you would mark what they're seeing based on what side they're looking at. All of these various components are brought into conducting this assessment. In the end, you might have hundreds and hundreds of data points for an individual using this test. But the reality is, this is really, really hard to do. And it continues, even though we have the Exner system, and the Exner system actually has great reliability, it's difficult and it continues to be quite controversial. Part of this is because despite the system being regimented, most clinicians still will find themselves using it in their own way with their own administration and interpretation. When that happens, the relatively reliable system becomes no longer such. It's no longer consistent, which means it can no longer be valid, and it's less useful as a diagnostic test. However, it can be great for icebreakers, for getting a sense of how a person thinks, and for providing some supplemental information to be used for a diagnosis, but it should not be used for a diagnosis in and of itself or on its own. So let's go into a little bit about what they look like. This is an image of all of the Inkblots on one poster. And some things to notice here is you see differences with perspective of if it looks like you're looking down from far away or if you're looking directly on. Some have color, some do not. Some imply some motion or action that the characters might be taking and others don't. All of these are the kinds of things that would be identified for that particular Inkblot, and you would record. Did they use the color or not? Did their image imply motion? I encourage you to, for each of these, pause and write down as many different things that you notice. In this particular one, we might look at, did they use the whole picture or did they look at little details? Was their theme common or unusual? Did they imply any movement or shading? And I also want to emphasize, you never think about their one response for a diagnosis. You'd want to look at all of their responses across all of the cards, including these variety of themes. Here, one thing that's often very common is people seeing the entire thing as a face, maybe a grimacing face, maybe a fox, where the two white spaces in the center are eyes, and then that long white space looks a bit like a mouth. Sometimes people will see elephants in this picture, where the sides are their ears, and then their trunks are meeting together in the middle. Sometimes people see this as witches or people with a cape going around a center pole and their capes are flying behind them. And recall, you would also ask the person to turn the shape each direction. As you can see here, if it's upside down or rotated, it might bring on completely different images and a whole other set of responses. In this image, people often talk about somebody riding a bike or a motorcycle, and so their feet seem really, really large, like they're about to roll over you and their head is way far in the distance. Others will see the handlebars of the motorcycle as two geese heads and necks. And where the motorcycle tire is, sometimes people will see as a big bug. In this example, it would be very common for people to look at the two items floating off at the top and think that these look like a candelabra or candles, old-fashioned kind of candle holders with a lighted candle. In the center, some people see tuxedo, some people see a frog. I wish we were together today to hear what you're seeing. And it's also very common for people to look at this image and without using the two pieces of red on the side, they will see two women that are bent over a wash basin and washing clothes the old-fashioned way. Moving on to personality inventories. Unlike our projective tests that were informed by psychoanalytic theory, the personality inventories are not theory-driven. They tend to be empirically driven, which means data-driven. And when I say data-driven, it doesn't mean that you would look at the item and necessarily know what it's getting at. That's called face validity, but it is still driven by the data and the research. As an example, if people with multiple personality disorder tend to say, I don't like watching TV on Sundays, then it doesn't matter whether or not watching TV is actually linked to that disorder. The fact that a particular group of people answer that in the same way and that it predicts their group membership is all that matters. So again, the importance here is really what it is predicting, regardless of if it's face valid or if it makes any logical sense that it's predicting in that way. The most common of the personality inventories is the Minnesota Multiphasic Personality Inventory. You may have also heard of it as the MMPI. The MMPI first came out in 1943. If you recall, that means it is older than our DSM. And it was developed by comparing item responses between a number of psychiatric groups and non-psychiatric groups. Again, if significantly more people with depression said yes to an item like, I only drink warm water, then that item would be added to the depression scale, even though warm water has nothing to do with depression. The MMPI is a true-false inventory with very simple questions. I cry easily. I'm happy most of the time. I believe I'm being followed. Someone has been trying to poison me. And people simply go down the list and say yes, no, yes, no. When looking at their scores, we don't look at their individual answers to any individual questions. What's important here is their pattern of responses across all of the questions, and there are a lot. Those questions are then broken into subscales. Subscales like depression, where you see a lot of negativity, low morale and helplessness, versus a schizophrenia scale, where they're reporting very suspicious beliefs or unusual thoughts, or a hypochondriasis scale, where they're talking about a lot of bodily concerns and complaints. What's nice about the personality inventories is that in addition to those clinical scales, they also have a variety of scales that help you understand if the person's answers are reliable and valid. The validity scales assess things like whether or not somebody might be downplaying their problems or kind of faking good. They fake like they're doing really well. But also the opposite. Are they faking bad? Are they trying to make themselves look like they are functioning worse than they are? It can also determine if people are answering the questions randomly, if they are having trouble reading the questions, or if they are responding in a very defensive way. By having the validity scales, the clinician is able to determine the validity of their overall profile and how they should adjust or use the test scores based on those validity scales. Some nice things about the MMPI now is that it is computer scored, so you can have the data go in and shoot out a profile and even shoot out a basic interpretation. It's far more reliable than projective tests and has standardization procedures that make it pretty similar when administering across different people, and it can be very easy to administer. There are, however, still problems. Just as you see with projective tests, some clinicians still interpret it their own way instead of following what the science says to do with it. It's also incredibly long. There are 567 items, which means even strong readers are going to take anywhere from 1 to 2 hours to complete this test. And this is simply too long for some contexts. And even though the wording is often simple, it can be a reading level that might challenge some individuals. But to address this, they have done things like it's now been translated into many different languages. It can be read to the person and then they put their responses down. They even have computerized versions where maybe it will capture their responses after they've read the item to them. The take-home message here is, when we go about the process of clinical assessment, we use many different tools, and those different tools have a different purpose and make different contributions